Our next presenter is Dr. Douglas Glod. Dr. Glod is the Chief of Podiatry at the Memorial Hospital of Rhode Island and the Clinical Assistant Professor of Podiatric Medicine at Brown Medical School. He specializes in reconstructive foot and ankle surgery along with limb salvage, like Dr. Goss, in the diabetic and high-risk patient population. So now he'll be talking about how he's used DynaNail to treat large segmental defects. Uh-oh. I think you're still on mute.
There you go. I'm still on mute. I wanted to say thank you very much for allowing me to come here and speak on this panel. I'm very impressed with the lectures that have been given to date. I'm going to be talking a little bit about my experience with the use of bulk bone grafts and the DynaNail when you have massive segmental defects of the ankle. There are many reasons as to why your patient will come into your office that has an actual massive defect, and most commonly it's going to be the result post-traumatic, which could possibly lead to avascular necrosis of the talus over time. I've seen it with total ankle arthroplasty failure, neuroarthropathy, and less common in osteomyelitis and neoplasms, but it certainly can happen. There are a number of options that you can utilize when you do have large massive segmental defects. Most patients that I have come to me already with bracing, and it's failed. They've been told that their only other option is amputation, but is that really the case? If you think about it, there are a number of other options from a surgical point of view that you can consider, such as tibial calcaneal fusion, distraction osteogenesis, titanium spacers, and also bulk allogenic bone grafting. What I'd like to do is just sort of review the literature of each of these options so we can get a feel for maybe perhaps what's going to be the best option for the patient. Tibial calcaneal fusion's literature review is pretty widespread. It's been done for many, many, many years. When you look at things like the non-union rate and success rate, you'll find that that the spectrum can be anywhere between 25% to 80% of failures. After looking at this, I realized that there's really a huge difference in when you think about the timing of this. Pre-1990, things weren't too good with tibial calcaneal fusions. You roughly had a 45 to 80% chance of a non-union rate. Post-1990, the non-union rate went down to about 25 to 45%, and I attribute this primarily to the technology that has advanced us with osteosynthesis, all the different types of internal fixation and orthobiologics and so forth. But even if you did succeed to not get a non-union, if you were that 50%, you still have other issues to consider when having a tibial calcaneal fusion. More so the fact that you're left with a shortened limb, and you're going to need to compensate for that. That means you're going to have that patient with an increased pelvic tilt, you're going to have increased knee flexion on the long extremity, and an anterior equinus of the forefoot of the short extremity. And suffice it to say, these patients, although, yes, you salvage the limb, it's really not that great of a situation for them. Distraction osteogenesis, I've had very little experience with this. I've used it mostly in the forefoot. And when I started to look in the literature, there's really not a heck of a lot of studies out there that have been showing large case numbers. It's not a single stage procedure. It has a prolonged recuperation. You have to deal with pain and pain management, pin care, pin tract infections, personal hygiene. All of these things are potentially issues. And then the question comes about with how do you maintain that correction? As you lengthen the bone, that bone that you're left with is very soft and very spongy. So if you do not protect that patient post-operatively for a long period of time, they could get or develop an angular deformity or perhaps even a fracture through that callus, and the end result is you lose correction. So these are things you have to consider when you're talking about distraction osteogenesis. Titanium spacers I've also not had that much experience with. There's only one individual that I'm aware of that I'm good friends with that has had a total of 12 cases that he's done this on, and 11 of them were successful. And one, the titanium spacer, split the calcaneus in half into an anterior and posterior part. I've asked him to published it, publishes information that he has, because there's literally very little out there, and he is going to consider that. His name's Chuck Zellin. But the success rate, the length of time to incorporate this titanium spacer and have it bond to bone, all this is still relatively in its infancy. We don't know what the average time frame is for all these things. So experimental, in my opinion. There was another individual that did publish something regarding a titanium type of a spacer, and what they did was they actually had a cylindrical cage that they were able to fill with composite bone graft and then use that in combination with an IM nail. This is just simply a case report. It's not a whole entire series. And this patient did very well. Unfortunately, went on for a bony amputation 9 months post-surgery. But this wasn't because of the failure of the graft in the cage. This individual actually suffered a calcaneal fracture and didn't want to go on for any further surgery, so the end result was a below-knee amputation. And then we get to something that I want to talk about more in detail, more in depth, and that's the use of large bone block allograft, or a femoral head is what I particularly use, to fill these large defects and get these limbs to be of correct size and functionality. One of the nice things about utilizing allograft like the femoral head is that it's readily available. And it also is going to typically meet the volume and structural demands of axial loading inside of a situation where you don't have a talus. The question that's come about is, how long does it take to incorporate the graft? It's a very difficult task. It's a large piece of dead bone, and it's going to not incorporate in 3 months or 6 months. It's going to take years for this thing to become totally incorporated. And then when you think about it, you look at the literature, I'm going to review the literature with you, that there are few reports that exist to guide the surgeon regarding the outcome and expectations, very few. So the first study or first paper that I came across was done by Thomason. It was a 3-patient case report. The thickness of the graft was anywhere between 25 to 28 millimeters, which I consider to be a bulk bone graft. Time to union, in their opinion, was roughly 3 months, and the age group ranged from 46 to 86. So they had 100% success in 3 patients, but obviously that's not a statistically significant situation. And then you have a study that was published by Jen, 32 patients between 2005 and 2012. 16 people healed their fusion, which is roughly 50%. 23 patients were braceable, and 6 patients resulted in a below-knee amputation. And what was interesting was that they had 9 diabetics, and they came out with one fact, that was that diabetes was the only predictor of outcome. All 9 patients developing non-union, and almost all of those 6 patients resulted in below-knee amputation. So that really goes on to what our 2 other presenters have mentioned, that diabetics don't heal these things very well. Then I came across this article. It was by Paul, published in Journal of Foot and Ankle Surgery, 6-patient case report. Now this was bulk bone grafting, but it was utilizing a allogenic type bone. They basically used the fibula as an ipsilateral circular pillar autograft in combination with an IM nail. The mean follow-up was roughly 26 months, 12 to 34 months overall, and all cases fused solid. And this is what it looked like. They basically took the fibula, cut it up into chunks, put it circularly around the IM nail. They felt to add rigidity that they would add a plate onto it. And this cross-section that you see over here is what it looks like. You can see the fibula all the way around circularly in a pattern. Now, there are many different types of ways to achieve arthrodesis with respect to internal fixation and external fixation. You have plates and screws, you have the IM nail, and you also have external fixation. All of these are options that are good. I think that it depends, which is going to be most successful for you is going to be depending upon your experience. Whenever I'm doing any type of high-risk surgery on patients that are diabetics or have multiple surgical procedures that have been performed in a particular area, I always try to give myself the best advantage, and that's going to be to try to augment this, augment it with autologous bone marrow aspirate, platelet-rich plasma, any type of orthobiologic that's going to help this to heal. So even if you use everything, including the kitchen sink, the best laid plans don't always work out the way we want. And then you develop this, what I call the black line of death, the non-union. And you ask yourself, how did this happen? Why did this happen? You did everything you could possibly do to prepare this, and yet it occurs. And it occurs to everyone. Everyone's going to see these things. And after doing a lot of research and looking at the articles that are out there, it came to me that a successful arthrodesis requires a combination of stability and rigidity. And before I was looking into this stuff, I thought that stability and rigidity was pretty much the same thought process. And in actuality, they're completely different thoughts. Stability is defined as maximizing bone-to-bone contact and limiting micromotion. So you want to have as much bony surface coacted against bony surface, and then compression to limit micromotion in itself. Rigidity is going to be defined as preventing excessive bending and shear and torsion of the formation. So you want something that's going to really hold this thing together. And it's the combination of stability and rigidity that's going to give you the best chance for fusion. Now, there were a number of studies that looked into this. And Muckley, in his study, came up with a comment that I include here, that there's a predictable loss of compression due to an in vivo response, that being resorption of bone, affecting all static internal devices equally. So you're always going to have resorption of bone. And as was said by Dr. Hero, you're going to get a tremendous amount of resorption of bone in the diabetic population. I theorize that's why, if you looked at that study where they had all 9 diabetic patients failing, that this is what was going on. Chang published in Podiatry Institute Update, this was a review or an evaluation comparing screws and staples, memory metal staples. They found that a complete loss of compression with screws was known to occur with as little as 0.1 millimeters simulated resorption of bone. That's not a lot of resorption of bone. Now, Pelton, in October 2006, Foot and Ankle Institute International, averaged 2.3 millimeters of bone resorption can occur through impaction and diamization. So when you're doing these types of procedures with respect to pantalar fusions or the sort, you're going to get resorption of bone, and that resorption of bone can be substantial. Now, how do you deal with resorption of bone? Well, you can deal with it through compressive fixation, and there are 2 ways that you can achieve it. You can achieve it through external fixation, and you can affect it through the use of the DynaNail. Now, Yakaki in 2010 did an evaluation on simulating bone resorption and what happens to different forms of internal fixation. And he found that 90% of the compressive load is lost after 1 millimeter of resorption with static iron nails. 1 millimeter of resorption is not that much. And if you look at compare it to the external fixation or the DynaNail, over 6 millimeters of resorption before 90% of the compressive load is gone. And that's pretty significant. So what is the DynaNail? Many of you here are familiar with it. Some of you have used it. This is what it looks like. This is a cutaway of the DynaNail. You have that nail configuration with the proximal and distal screws, but you also have in the center a metal filament made of nitinol, which is the compressive element. And this is a little video showing you that compressive element being stretched. You can see how it wants to pull it back together. And this is what the DynaNail is all about, active and dynamic compression. So let's get back to all those different thought processes on how you can salvage these types of massive bulk bone loss. You can use the tibial calcaneal fusion, you can do callus distraction, you can use titanium spacers, or consider the use of femoral head allograft. And when you think about the amount of bone resorption that occurs, you have to wonder, if you don't have dynamic compression, are all of these cases, or most of these cases, going to fail? And the answer is probably yes. I just want to review with you this one particular case. This is a case that was utilized in a study that we're in the process of publishing. It's rather interesting, but at the same point in time, it shows you what can sometimes happen with crack. 2003, patient comes in to see an orthopedic surgeon, and he ends up having a diagnosis of severe osteoarthritis and recommended for a partial talar transplant, as you can see here. It actually worked out pretty well, and if you look at the literature on these things, they last anywhere between 4 to 6 years. That buys them time before they need to have something else done. This is what he looked like in 2012. Unfortunately, avascular necrosis and collapse of the talus. If he had come in earlier, he might have been able to get away with an ankle implant, but at this point in time, most of that talus is avascular necrosis. So he went back to the primary surgeon, who recommended either a tibial calcaneal fusion, which he did not want to have, and or amputation. And obviously, he didn't want to go for that. So he came to me because I was a star ankle implant person, and he thought maybe I could put an implant in. My recommendations to him was either a tibial calcaneal fusion, a fusion with a bulk bone graft, or amputation. None of these things were things that he really wanted to have. He wanted to have range of motion of the ankle joint. And after a long discussion with this gentleman, I actually offered him one other option, which was pretty much experimental, and that's a talar transplant. He was willing to go for it, and that's what we did. So here's a fresh frozen talar transplant being placed inside the ankle joint. This is a CT scan of the ankle joint 6 weeks post-op. You can see that the talus is relatively fused to the calcaneus. This was utilized with OP1 as an orthobiologic, also with bone marrow aspirate. So we were able to achieve fusion, but that doesn't mean that the talus that is resulting there has become fully vascularized. That could take several years before that happened. It may not even happen. But this seemed to work out pretty well. And he was actually having excellent function, and this is what he looked like 6 months post-transplant. Shortly after that, though, he started to develop pain inside the ankle joint with range of motion, and this got to the point where he could not move the ankle or put weight on it at all. So we were left with very minimal options, either do a pan-talar fusion or a total ankle joint replacement. Again, the patient really didn't want to do fusion. He wanted to try a total ankle replacement. I presented this case to the board of directors and the panel of star implant surgeons, and they thought that this would be reasonable to attempt a total ankle replacement since it's primarily axial loading. So we did it, and it came out nice. And this is 8 months post-transplant. The patient was very satisfied, normal range of motion to the ankle joint for an ankle implant, and in fact, he was working on this very diligently with a physical therapist. Bottom line is that approximately, hold on a second, just gotta get this thing here. 4 months post total ankle replacement, patient felt a pop while performing physical therapy. Patient noted increased swelling. We get x-rays, and this is what we see. Complete collapse. So now what are we left with? We're left with either a tibial calcaneal fusion, which is what was suggested in the beginning, or perhaps we're talking about doing an amputation. And after discussion and evaluation and workup of this patient, the thought process was to actually try bulk bone graft. So this is what we did. We were trying to work up for infection. We put them in. We took multiple bone biopsies. We did 6 weeks IV antibiotic therapy, antibiotic impregnated polymethylene methacrylate, basically sterilized the area. We didn't want to do anything unless we were positive that there was no infection. And then the reconstruction was going to use a femoral head. Top and bottom of the femoral head sliced off. We would prepare the inner aspect of the femoral head by drilling holes and using autologous bone, which is fibula, and then insert using a DynaNail for stabilization. So this is just a quick video showing what we did. Pretty much all the dissections done. The bone graft that we took has been sized and placed inside the ankle joint region, and then we pretty much ream as if we're putting the IM nail in. Once we get the hole of the correct size, then we pull the implant out, and then we're going to prepare it. And we prepare it using everything that we can possibly do to make this become a success. What we do is we drill sequential holes all around the periphery of the bone graft, being careful not to violate the larger hole or the cortex. And once we drill all the holes, then what we do is we take the fibula and we will morselize it inside of a bone grinding machine, a bone mill. And we grind it several times to make the particulate matter very small, and then what we do is pack that into each of these holes completely so that we have a combination of allogenic bone and autologous bone all compressed and put together. We also augment this with bone marrow aspirate. We used to use OP1, and that's no longer offered in the United States, so we just use whatever we have available. So you can see this being packed in. It's very time-consuming. Another way to do this is just to split the fibula into small matchstick shapes and then fill that or push that into the holes. And this is the bone marrow aspirate being dripped right into the graft, the composite graft. So this is what this looks like. If you look at the bone graft itself, it's massive. It's not 28 or 25 millimeters. This is a 42 millimeter bone graft that we're using here. And it's in combination with the use of the DynaNail. You can see this is a CT scan showing you various sequential slices. You can see that there is some incorporation of the graft at the host site. And the graft is not completely incorporated at this point in time. It's just attached to the bone. It's basically fused to the bone. There's a sagittal plane view. So we did a number of these types of procedures, and we were having pretty good success with it. We thought that maybe this would be something we could share with the public. So right now we're in the process of getting this study that we did, retrospective, ready for publication. Right now we have 7 patients who had large segmental defects, loss of talus. 6 of them were diabetic. 5 patients had neuropathy and charcot arthropathy. 2 were post-traumatic with AVN of the talus. All utilized allogenic fresh frozen cadaver femoral head prepared with autologous bone, as I showed you. Our results: mean patient age 54 years, mean initial graft height 32 millimeters, but the range was 25 to 42. Mean loss of graft height at average of 11.2 months was almost 3 millimeters. So you've got a lot of resorption of bone. And if you have that much resorption of bone, I'm sure you'll find that every single static device that you're going to use is going to fail. You're going to wind up with a non-union. You're going to have instability, more resorption of bone, and complete failure. The mean time to radiographic evidence of a host incorporation or actual attachment of the graft to the host was 6.8 months. 5 fully fused with pain-free function in normal shoe gear, and I mean that, normal shoe gear, not being braced. 2 demonstrated partial fusion with fracture of the bone graft, currently functioning full weight bearing in a CRO and an AFO. And these partial fusions with the fracture of the bone graft, we attribute that to overcompression. The DynaNail, you have the dial-in compression that's available, but you can also compress on top of that. And we were compressing maximum compression, and we think that that was what probably caused or led to the fracture of the bone graft, and hence now we don't do that. So this is what the fracture of the bone graft looked like. And as I said before, both of those patients are functioning pretty well. The pearls that I have to offer you with respect to large segmental bone defects is use everything you can to get this thing to heal. And when you're using an IM nail, use the longest nail possible. It's going to add to your rigidity, and it's going to augment the stability of your arthrodesis site. And then key is dynamic compression. If you don't have dynamic compression on these types of cases, it's going to fail without question. These are very difficult cases, and I think that we're beginning to find that with augmentation, with the use of the DynaNail, you can use large bulk bone grafts in cases where axial loading is a viable option. And that's it. Thank you.